Hello everyone. Indian Society of Electrocardiology is conducting ECG learning courses basically for the postgraduate students as well as for the physicians who are interested in learning ECG. Basically, if you want to learn an abnormal ECG, I think it's very important to learn a normal ECG. I'll be discussing in my class or in my lecture about the normal ECG, some technical problems and the variants. When we record an ECG, what is an electrocardiogram? It's the recording of the electrical activity which is generated by the cells of the heart that reaches the body surface. So that's how the term is generated as electrocardiogram. ECG is recorded by a device which is like a galvanometer, which is a sophisticated galvanometer where there are two poles, positive and a negative pole, and the electrical impulses are moving from the positive to the negative pole, and the impulses, the ECG is being recorded. Like if you see this slide, there is a ECG impulse which is moving from negative to the positive pole, and the ECG is being recorded at the above the basal surface. And when the electrical impulses are moving from positive to the negative pole, then the ECG is recorded below the baseline. These changes are recorded on a graph paper as a voltage on the vertical axis and the time on the horizontal axis. And each lead provides a view of the electrical activity as seen from its particular position on the body surface. Basically, the normal ECG has got 12 leads. There are 6 limb leads and 6 chest leads. The limb leads are also called as frontal plane leads, and there are lead 1, lead 2, lead 3, AVR, AVL and AVF, and the chest leads are also called as transverse plane leads, which are from V1 to V6. There can be many more leads, but standard ECG has got these 12 leads. The lead 1, 2 and 3 are bipolar leads, and AVR, AVL and AVF are unipolar leads. When the unipolar leads have got a very small voltage, so to augment we do the augmentation, that's why it's called as AVR, AVL and AVF. This is a basic diagram for the axis, and there is a separate lecture on the axis, so I will not be touching too much on the axis part. Basically, the impulses are generated at the SA node in the heart. From SA node, the impulses traverse through the atria, then they traverse to the ventricles, and the impulses, when they are traveling from the SA node to the AV node, then the P wave is formed, and when the impulses are traveling through the ventricles, then the QRS complex is being generated. These are the depolarization of the cardia, and when there is a repolarization, then the ST and T wave is being formed. I think very important is to placement of the chest leads. If we do not place the chest leads properly, then the impulses, the ECG recorded is not correct. So it's very important to know the exact location of the chest leads, and I have mentioned to you earlier that we have got V1 to V6 leads. V1 is located on the right side in the mid on the right parasternal side on the fourth intercostal space. V2 is on the left fourth intercostal space, just parasternally. V4 is in the mid clavicular line in the fifth left intercostal space, and V3 is in between V2 and V4. Then after V4 we do not, it is in the same line. V5 is in the mid axillary line, and V5 is in the anti-axillary line, and V6 is in the mid axillary line. This is again showing the same V1 to V6 locations and the axis of different vectors. This was I was mentioning about the graph paper where the ECG is being recorded, and we record the voltage on the vertical axis and time on the horizontal axis. This is the graph paper when a small square is 0.1 millivolt, or 1 millimeter is equal to 0.1 millivolt, and when we are talking of the horizontal axis, the time, it is one small square is equivalent to 0.04 second or 40 milliseconds. Now we come to the basic ECG deflections, and this is the classical PQRST complex. where the first wave is the P wave followed by a PR segment, then we have got a QRS complex, then followed by an ST segment and a T wave. So normally we have got a P, QRS and T wave, and then we have got two segments, PR segment and the ST segment. And then there are two intervals are there. One is from the beginning of P wave to the beginning of QRS complex, which is the PR interval, and from the beginning of QRS complex till the end of the T wave is the QT interval. I will be talking about these things in next few slides. I think let's come back to the P wave, which is the first wave of the ECG complex, which has got a very smooth contour, which is a monophasic wave, except in V1 where it may be biphasic. Then normally the P wave is positive in lead 1, lead 2, AVF, V4 to V6, and it is always negative in AVR, and it is variable in other leads. The amplitude of the P wave is less than 2.5 millivolt, or it's 2.5 millimeter, and the duration of P wave is less than 120 milliseconds. P wave, I have told you that it may be biphasic in V1. If it is biphasic in V1, then the positive initial component of the P wave is less than 1.5 millimeter in amplitude, and the negative terminal component is less than 1 millimeter in depth and less than 40 milliseconds in the duration. If it is more than that, then it is abnormal. Then the PR interval, I have told you that the PR interval is basically from the beginning of the P wave till the beginning of the QRS complex, and the normal duration of the PR interval is 120 to 200 milliseconds, that is 3 to 5 small squares. PR segment is after the P wave till the beginning of QR complex, and it is usually it represents the duration of the conduction from the AV node down to the bundle of His through the bundle branches to the muscle, and it is usually isoelectric to the baseline. And normally when we talk of the baseline, it is basically the TP segment at the end of the T wave till the beginning of P wave, that is we take as an isoelectric line, and this PR segment is isoelectric to the TP segment. The second major deflection after the P wave is the QRS complex, which represents the ventricular depolarization. The duration of QRS complex is less than 110 milliseconds, and normally if you see in the V1, there is a small R wave and a deep S wave, and then it moves to the V6 where there is a small, in V6 there is a small Q wave and a major R wave, and in between there is a transition zone where the R wave and the S waves are equal. Normally this transition zone is between V2 to V4. When we talk of the QRS, we talk of the nomenclature. When we are writing QRS, by the written QRS, one can see, one can understand the depth of the Q wave or the depth or what is the height of the R wave. If there is a small Q wave, then we write a small q. If it's a major Q wave, then we write a big Q. Similarly, we write the different nomenclatures. Basically the first initial downward deflection after the P wave is the Q wave. Then the first initial upward deflection after the P wave is the R wave. And the negative deflection after the R wave is the S wave. And after that, sometimes there are many more deflections which are being represented as R dash or RR dash or S dash or SS dash. I told you when we are writing a QRS, you can see on the screen that when we are writing the QRS complexes, when we are writing like a Q, large R and small s, it represents that there is a small Q wave and a big R wave and a small S wave. Similarly, if we are writing an RS, it means there is a major R wave and there is a small S wave. Similarly, the other waves are being depicted here with different nomenclatures. I mentioned to you that the impulses are generated from the SA node, then it comes to the AV node, and from AV node it goes down to the bundle of His, and then it goes into the right and the left ventricles. And this is how the waves are being generated and waves are being formed on the ECG paper. Then we talk of the Q wave. The Q wave, I have told you, it's the first initial downward deflection after the P wave. The Q wave of any size in lead 3 and AVR is normal. So one shall not say, if we are seeing a Q wave in lead 3 and AVR, one shall not say it's an old inferior wall MI, because Q wave can be present in lead 3 and AVR. A non-pathological Q wave is less than 40 milliseconds in duration, and it is less than 25% of the ensuing R wave in amplitude. So if the Q wave is more than 40 milliseconds, or if it is more than 25% of the ensuing R wave in amplitude, then it is abnormal. Such small Q waves are present in left precordial leads in almost 3/4 of the normal subjects, in one or more inferior leads in almost half of the normal subjects, and it is also present in lead 1 and AVL in less than half of the subjects. You may see a QS complex in V1, sometimes you may see a QS complex in V2 also. Then after the Q wave, the first initial upward deflection is the R wave. Normally R wave can be absent in V1 and rarely it may be absent even in V2. Then gradually the R wave amplitudes keeps on increasing from V1 to V4. Tallest R wave is usually in V4 followed by in V5. The amplitude of R wave in V6 is usually lower than the V5. After the R wave, then there is a negative downward deflection, which is an S wave. It is prominent in AVR. Usually S wave is large in V1 and it is largest in V2. Then gradually the S wave becomes smaller and smaller from V3 to V6, and S wave may be absent in V5 and V6. After the QRS complex, then we have got again a segment which is called an ST segment. From here the repolarization starts. ST segment begins at the end of the QRS complex and ends at the onset of the T wave. It represents unchanged polarization between the end of depolarization and beginning of repolarization. It is normally again an isoelectric, and deviation of 0.1 millivolt or one small square can be considered normal. Always ECG has to be interpreted in the light of the history. So if there is no history and there is a mild ST segment depression or mild ST segment elevation of 0.1 millimode, it may be considered as normal. And I have mentioned to you the isoelectric line, which is the TP segment, and the ST elevation or depression is also measured with reference to the isoelectric baseline, which is TP segment. Then one of the waves which is at the end of the ST segment is the T wave. It again represents ventricular repolarization. Usually it is smooth, round and asymmetric. The amplitude of T wave is usually less than 0.6 millivolt in limb leads and less than 1 millivolt in the precordial leads. Always inverted in AVR, always upright in lead 1, lead 2 and V4 to V6. May be upright or inverted in lead 3 and AVL. Usually upright but can be flat or slightly inverted in AVF. Upright, inverted or biphasic in V1, sometimes in V2 and V3. One of the very important intervals is called as QT interval. It represents the total duration of ventricular depolarization-repolarization cycle. The QT interval begins at the onset of QRS complex and ends at the end point of the T wave. Normally the QT interval varies because of the heart rate. If heart rate is slower, then the QT interval is larger, and if heart rate is fast, then the QT interval is shorter. So we have to correct the QT interval as compared to the heart rate. That is called as corrected QT interval, and basically there is a Bézard's formula is there for corrected QT interval, which is QT interval divided by under root of RR. Usually in men the QT interval is less than 430 milliseconds, and in women it is less than 450 milliseconds. Then sometimes after the T wave we see a U wave. U wave is a small deflection that appears after the T wave before the following P wave. Can be normally absent, and if present it is best seen in V2 and V2 to V4. Normally the U wave vector or the direction of the U wave is similar to the direction of the T wave. The vector of U wave is similar to the vector of the T wave, and usually it is negative in AVR and occasionally it is negative in leads like lead 3. The amplitude of U wave is less than 25% of the T wave amplitude. I have told you that QRS axis is usually between -30 to plus 110 degree in frontal plane, and there is a separate lecture on the QRS axis, so I will not be discussing more on the QRS axis in this lecture. Once we have seen the different waves, then when we are reading an ECG, I think the first and foremost thing is to know what is the rate of the heart rate and what is the rhythm on the ECG. The normal rhythm is usually a sinus rhythm where the P wave morphology is normal and similar. Each P wave is followed by a QRS complex and each QRS complex is preceded by P wave. That is a sinus rhythm. The PP interval are essentially constant, so that the rhythm is essentially regular. Sometimes there may be the rhythm may be slightly irregular, which is called as sinus arrhythmia, which may have a significant variation. Normally, the heart rate is between 50 to 100 beats per minute during wakefulness or during when the person is awake. This is one of the normal ECG where you will see that there is a P wave, there is a QRS complex and the T wave. There is a P wave, there is a QRS complex and the T wave. Each P wave is followed by a QRS complex and the T wave, and each QRS complex is preceded by a P wave. And the RR intervals are almost regular, or the PP intervals are all regular. So this is a classical sinus rhythm ECG. Then I will be talking of some normal variants, basically sinus arrhythmia, athlete's heart. There is a separate lecture on early repolarization syndrome. Then the persistent juvenile pattern, and sometimes you see an RSR pattern in V1. I have mentioned to you one normal ECG, and the sinus arrhythmia is again each P wave is followed by a QRS complex, and each QRS complex is preceded by a P wave. But the PP interval vary more than 10% with acceleration in rate during inspiration, and it slows down during expiration. Sometimes it is so marked that one may confuse with clinically important arrhythmias. This is one ECG of sinus arrhythmia where you are seeing that each P wave is followed by a QRS complex, each P wave is followed by a QRS complex, and each QRS complex is preceded by a P wave. But rate is somewhere the rate is increasing and somewhere the rate is decreasing. So this is during inspiration and this is during expiration. So this is a physiological sinus arrhythmia. Athlete's heart has got so many ECG findings that could be abnormal for a normal person, but for athlete it may be normal. One can have sinus bradycardia, one can have first degree AV block, one can have increased QRS voltages, increased labile T wave changes. And when we are doing an Holter on an athlete, you may see AV blocks with Wenke back, junctional escape complexes or junctional escape rhythms, which you consider abnormal in a normal person. These changes becomes less pronounced or disappear when there is a cessation of training, and they may reappear again. I have talked to you that early repolarization will be discussed more in detail, but it is present in 1 to 2% of the general population. It has got male preponderance, and it's common in athletes. There is a minimal concave upward SC segment elevation and prominent J waves in mid precordial leads, often with tall T waves. It is often associated with slow sinus rate. This is one example of the early repolarization where you are seeing then there is a small SC segment elevation or a small J point elevation. In my initial slide, I mentioned to you that T waves are inverted basically in V1 to V2. Sometimes T waves may be inverted in V3, but normally in adults the T waves are never inverted in V4. But in children the T waves are inverted up to V4. Sometimes this ECG pattern is present in adults. So this is called as persistent juvenile pattern where T wave inversions you may see from V1 to V4. This is one of the ECG where you are seeing a T wave inversion in V1, V2 and V3, and sometimes you may see even T wave inversion in V4. This is a retrospective finding. When we keep on following the ECG from childhood till adulthood, then only we can say it's a persistent juvenile pattern. Sometimes you may see a small RSR pattern in V1. Normally it may be seen in 2.4% of the healthy individuals. So this is the one again of a normal variant. Now I will be talking to you some technical problems. Sometimes we have got when we are connecting the ECG machine to the electrical cable, then there can be an AC means interference where you see the vibration on the ECG, which is because of the ECG or AC means interference. Sometimes if the wires are loose, then there can be a wandering baseline. So this is one ECG which is showing a wandering baseline. So this is also an artifact or technical variation. Sometimes when ECG is being recorded in a very cold atmosphere or in a very thin individual, then there are somatic tremors are there. Sometimes in people who are suffering from Parkinsonism, they have got tremors. So the tremors are being also recorded on the ECG papers. So this is also one of the abnormal or technical variations in the when we are taking an ECG. So this is also when there are coarse tremors are there. Sometimes people may confuse this ECG with atrial fibrillation or atrial flutter, but if you see, the RR complexes are absolutely normal, and you will see at the end of the ECG you are seeing the normal P waves, but this is just somatic tremors or artifacts. This is one again an ECG of the ECG in the top panel is showing an artifact, while the ECG in the bottom panel is showing a true arrhythmia, and one can confuse the artifacts with the true arrhythmia. Only thing one should see that when you are seeing the RR waves, and you can see those spikes of RR waves in the ECG also in the arrhythmia or in the artifacts. So one has to closely see the normal ECG or the normal R waves in the course of so-called pseudoarrhythmia. And normally when we are talking of such patient, the patient will be totally asymptomatic. So artifacts one shall differentiate because there are absence of symptoms, there is no hemodynamic variation during the event. One may see a normal ventricular complexes appearing among those dysrhythmic beats. They are sometimes, I have told you about the wandering baseline, so they are associated with body movement. There is an instability of the baseline tracing during and immediately following the alleged arrhythmia, and one may see asynchronous visible notching consistent with the underlying ventricular rhythm marching through the pseudoarrhythmia. The other thing is which is important is the lead misplacements. Sometimes the technician who is taken a ECG may put the right limb lead electrode into the left limb or the left limb electrode into the right limb, and you may find a variation. So one should be very cautious about the lead misplacements. And the most common misplaced leads is if the complex in lead 1 appears upside down, then usually the left and the right arm leads are reversed, provided the precordial leads are not suggestive of mirror image dextrocardia. Because if the complex is in the lead 1 is negative, the most important diagnosis is either the misplaced leads or the mirror image dextrocardia. So one has to look the precordial leads. If the precordial leads are normal, then the likely it is a misplaced leads. And if you see this ECG on the panel which is on the right side, the lead 1 is showing in inverted complexes, and the precordial leads in this ECG in this patient was normal, and when the electrodes were placed properly, then you can see in the same patient the ECG is normal. If one of the standard limb leads like lead 2 or lead 3 is absolutely flat, then usually the RL leads are switched with one of the other limb leads. Like in this, the lead 2 is absolutely flat, then it's because of RA-RL interchange, and once the electrodes were put properly, then you can see the ECG has become normal. Sometimes even in precordium, there are electrodes, I have told you, there are electrodes, if the leads are put not properly, then again even in precordium there can be misplaced leads. And in this ECG, if you see the transition from V2 to V3, which is not the usual transition, and if the transition in V2 to V3, the transition is not okay. So this tells you that there is a misplacement of the precordial leads between V2 and V3. I think that covers the normal ECG, variants, and some technical problems regarding the taking of ECG. Thank you very much.